Okay, so welcome back to Just Hard Podcast, Real Nurses, Real Talk, Real Life, where we take the nursing textbook, drop it right into the hospital unit. This episode is all about breathing. We're going to take respiratory content, and we're going to try not to hyperventilate.
No promises. Today we're talking oxygenation, oxygen delivery devices, chest trauma, pneumothorax, pleural disorders, respiratory tumors, basically everything that makes students say, wait, what's the difference between ventilation and oxygenation again?
Okay, and if you've also ever confused hypoxia, hypoxemia, vice versa, this episode is for you.
All right, let's talk about some terminology. So, straight from your oxygenation unit, let's rapid fire the definitions.
Ventilation, movement of air in and out of the lungs.
Diffusion, movement from high concentration to low concentration.
Oxygenation, so oxygen moving from the alveoli into the blood.
Respiration, oxygen to the cells, CO2 away from the cells.
If air moves in and out, but oxygen doesn't cross into blood.
Well, that's a diffusion problem.
If oxygen gets into blood but doesn't reach tissues.
That's perfusion.
See the layers? So that is exam gold.
It sure is, yeah. So let's talk a little bit about hypoxia versus hypoxemia. Hypoxemia is low oxygen in arterial blood.
Hypoxia is low oxygen at the tissue level.
Yeah, you can have hypoxemia without severe tissue hypoxia right at first, at the beginning.
Okay? And prolonged hypoxemia leads to hypoxia and then organ dysfunction.
Yeah, so what are early signs of hypoxia? The first one I think of is shortness of breath.
You're going to probably have an increased respiratory rate.
Increased heart rate.
Restlessness.
Anxiety.
Any late signs?
Oh, yeah, decreased level of consciousness.
Cyanosis.
Yeah, if they're confused, don't blame it on their age. Check their oxygen.
And so now let's talk about this. When are we going to give oxygen? So memorize this.
Yeah, a PaO2 of less than 60. And we only see this on the ABG.
SaO2 less than 90%.
Yeah, and that's on that pulse oximeter, right?
Yep.
Oxygen therapy is used to treat or prevent hypoxia.
But caution with COPD patients and chronic hypercapnia. High oxygen can suppress their drive to breathe. So actually our drive to breathe comes to blow off that CO2 when they live in prolonged hypoxia or hypoxia. Their drive to breathe actually comes from the low oxygen. So if we get the oxygen too high, we can actually suppress that and knock it out almost, right?
Yeah, that's a big one. And that's really hard too, because if they're hypoxic and their O2 is low and we want to cautiously give O2, they're going to die without it. So that's a tough one. As a student and as we're learning, like that's hard as a nurse. Yeah.
Right. So kind of a balance there. Yeah. Difficult
sure
one to kind of learn and facilitate. Yep.
Yeah.
So we got oxygen delivery devices now, and NCLEX is going to love this. So let's break it down simply.
Yeah, so nasal cannula, these are low flow devices. First is a nasal cannula, 1 to 6 liters a minute.
Delivers 24 to 44% oxygen.
Yeah, that one's the most comfortable.
Yeah, most common as well, yeah.
Yeah, a memory tip, a nasal cannula is a chill patient. So if your patient's super anxious, restless, hypoxemia, we're not going to nasal cannula them.
And then look at that. So we had that 24% on the low end there. Room air is 21%. So we're just barely, they just need a little bit of extra support.
Little.
Yep.
Yeah.
Now we got a simple mask. So 5 to 10 liters per minute.
Yeah. 40 to 60% oxygen.
And this is going to be a short-term use.
Yeah. Then we have the partial rebreather, 8 to 10 liters per minute.
50 to 75% oxygen.
The reservoir bag must stay a third to a half full. So that way they're not rebreathing their CO2.
We got a non-rebreather as well, so at least 10 liters per minute.
Yeah, up to 90% oxygen.
One-way valves, so no CO2 rebreathing.
Yeah, non-rebreather equals things are getting serious. If they're on a non-rebreather, things aren't good.
Right, for sure.
Yeah.
Now we got some high-flow devices. So we got a Venturi mask. It's the most accurate oxygen concentration.
Yeah, I like a Venturi mask. I think it's just because it's fun to say. I don't know. Yeah. I like it. It's kind of fun. Yeah. It delivers 24% to 60% depending on the adapter that you have with it.
And this is going to be an exam favorite.
Yeah, that's true, right? Yeah. High flow nasal cannula. We saw a lot of this during COVID. I don't actually think I saw it very much until COVID. Like maybe 4 times in my career,
really?
And then COVID hit, and then, oh gosh, it seems like everybody had one, and now we're seeing it a lot. But with high flow, we need to heat it. Oh, what were you going to say?
Even on the telefloors, too, so this is not just ICU.
Oh, yeah, for reals, yeah.
Way more common, like you're saying. Too.
Yeah, now we see it all the time. Yeah, we used to be like, oh, they're too sick, they can't do it. Yeah, now like, nah, just high flow, no big deal. Yep. Yeah, so with high flow, we got to heat it.
You got to humidify it.
Yeah, and up to 60 liters per minute. I remember when Florence Nightingale and I were in nursing school, they were like, oh, anything greater than 4 liters in the nose is going to blow their nose off. And we're like, oh, yeah, let's blast this thing with 60 liters. I think the first time I saw that, I was like, what the what?
Right, yeah.
Yeah, crazy.
And then the effect on that, there's going to be some PEEP or that positive end expiratory pressure, and so there's going to be less dead space and a little bit of that PEEP effect.
Yeah, so a quick reference is the 4% rule. It's the most common clinical rule of thumb. So every 1 liter of oxygen delivery adds 4%. So room air is 21%. So if we put them on 2 liters per minute, then their FiO2 or inhaled oxygen delivery would be about 29%. So that's a quick little rule of thumb to think about how much FiO2 they're getting.
Awesome. Very good little trick there, Lisa.
Yeah.
And so now we're going to go into a commercial break.
Yeah. Let's do it. So, are you tired of feeling tired? Exhausted from that exhausting thing called existing?
Yes. Even blinking feels like cardio.
Then you need oxygen, the revolutionary gas that's sweeping the planet.
Wait, is that the invisible stuff that's literally everywhere?
That's right. Scientifically formulated with 2 powerful oxygen atoms per molecule.
Are you talking about O2?
Boom! Chemistry. When inhaled regularly, oxygen may help support energy production, cellular respiration, and not passing out during clinical.
Wait, I can feel it. My mitochondria are thriving. ATP production is through the roof.
Side effects may include improved consciousness, pinker lips, and continued survival.
This sounds expensive.
Absolutely not. Available worldwide, no prescription needed for most atmospheric applications.
What about specialty versions?
Ask your healthcare provider about concentrated options for when 21% just isn't cutting it.
Wow. So all I have to do is breathe?
Results may vary if you stop. Oxygen, because anaerobic metabolism is not the vibe. Do not attempt to live without oxygen. Supplies limited to planet Earth. Consult your alveoli before use.
Okay, so welcome back. We're going to talk about some CPAP versus BiPAP. We got a test question alert
Whoop,
here.
whoop.
Yeah. So CPAP, continuous positive airway pressure.
Continuous pressure throughout the respiration cycle.
Keeps the alveoli open.
BiPAP means 2 pressures.
Higher pressure for inhalation.
Lower pressure for exhalation.
So what's the take-home message there?
BiPAP increases tidal volume, eliminates CO2, and decreases the work of breathing.
What about retaining CO2?
BiPAP.
Okay, sounds good. Now we're going to switch to, we got some chest trauma. So we're going to look at ABCs or panic.
Never panic. Never panic. Yeah.
So motor vehicle collisions, major cause.
Yeah, management follows ABC.
Airway.
Breathing.
Circulation.
Yeah. Flail chest. This one's cool. If you haven't had a chance to Google it or go on YouTube, just type in flail chest. You'll see some legit videos on it. So this is when 3 or more ribs are fractured in 2 or more places.
And we're going to get paradoxical movement. So sucked in on inhale, bulges on exhale. And paradox there, that word just kind of means you see something that shouldn't happen. It's not expected with normal process there.
Yeah, that is such a great definition. Yeah, it kind of goes in the opposite of everything else.
Right.
Yeah, so the treatment for a flail chest is intubation and mechanical ventilation because they're just not breathing appropriately.
So pulmonary contusion, so alveolar bleeding plus edema.
It may worsen 12 to 24 hours after injury, so we don't see this initially on injury. This typically follows a chest trauma.
And we're going to watch for tachycardia, dyspnea, and cyanosis.
Yeah. All right, this is one of my favorites, pneumothorax. So this is a high-yield question. So pneumothorax means air in the pleural space.
Classic signs, sudden shortness of breath.
Decreased breath sounds on that side, that's collapsing.
And tracheal deviation, so that's going to be a late sign.
Yeah, that leads to attention pneumothorax. So what is happening here is air is entering the pleural space, but it cannot escape. It can't get out.
And pressure builds.
Yeah, then because of that pressure, the blood pressure is going to drop because it's pushing against the heart as well.
Okay, and then we're going to have JVD or jugular vein distension.
Yeah, and tracheal deviation is going to go towards the unaffected side.
And we might even see some shock.
Yeah, this is a true medical emergency. So what do? Let's put in a chest tube.
Yes. So students panic here, but don't panic, just like we said earlier.
Never panic.
Never panic.
Never panic.
So purpose, we're going to restore that negative pressure.
Yeah. So a chest tube, we call it a Pleuravac. It evacuates the pleural space. So this system has a collection chamber.
It's going to have water seal.
Yeah, and it's also going to have a suction control chamber.
We want to keep it below the chest level.
Yeah, we want gravity to help us. So gentle bubbling in that suction chamber is normal. So you see that suction chamber is also connected to the water seal. So bubbling in that is normal.
And then water seal bubbling continuously.
Yeah, continuous bubbling is not a normal thing. So we got to think an air leak in there. So basically when a patient takes a breath and there's a hole in the lung, the air leaks out that little hole and bubbles through the water seal. And that's how we can measure it. We can see how much air is leaking out. If it's a continuous bubbling, either the hole is getting bigger or maybe the patient's tubing has gotten disconnected.
Perfect. And then now we're going to take a look at some pleural disorders. So pleuritis, we got sharp stabbing pain.
Ooh, I've had that. Have you ever had pleuritis?
Not personally. My mom has, and it's
poor mom.
miserable.
Yes.
I imagine, yeah.
You should
'Cause
give her a
it's,
massage.
Like, literally the rubbing, like friction,
Yes.
right?
Yeah. It's terrible, that sharp stabbing pain. It gets worse with breathing because you're moving your pleural lining.
Yeah. And we got pleural effusion, so that's going to be fluid in the pleural space.
Yep. You may need a thoracentesis. Let's hear it for the IR nurses. Whoop, whoop.
Woo.
Yes.
This is Lisa's team over there.
That's
yeah.
it. That's it.
Yeah.
Yeah.
So what might we need? Oh, we just said that. Sorry, thoracentesis.
Yeah, you're good.
And then complication.
Yeah. So a complication of a thoracentesis, sticking a needle in that pleural space.
Yeah. Perfect. So yeah, we might actually create a pneumothorax.
Yeah, that would be bad.
Yeah.
That would be bad.
Very bad. Yeah.
Yeah.
We
So
don't, we don't like to trade we don't like to trade problems for new problems.
Right. And we don't want to create a problem.
Right.
Yeah. Yeah. I mean, sometimes problems follow me. I'm not going to lie. Okay. So the next one, empyema. Empyema, that is very similar to a pleural effusion in that there is collection of fluid in the pleural space. But in this case, it's really thick and it's really difficult to drain.
Okay. So yeah, so we are going to work to drain it though, like you said. And
Yep.
thicker, it's going to be a little more difficult. And we got to treat the infection and kind of get rid of that, right?
Yeah. Yeah. All right, so let's move on. Outside of the pleural space, let's talk about the lungs specifically. And let's talk a little bit about lung cancer and laryngeal cancer. So with lung cancer, it's the #1 cancer killer, #1 disease that's killing folks.
Risk factors are going to be tobacco.
Obviously.
Yeah, and any form, right? So like
Yeah.
chew, snuff, smoking, cigars, tobacco, any form.
Vaping, all the
Vaping,
things.
yeah.
Breathing. I mean,
Yeah.
no, breathing's good. Breathing's good. Yeah.
Radon also, and then being over the age of 50.
Yeah.
So
I
just-
mean, you're dying when you're aging. Like, it's over for me, basically. All right. Symptoms, a new cough, hemoptysis, so blood in our sputum, shortness of breath, and hoarseness, so a change to the voice quality.
And then if we go to laryngeal cancer now, so our most important risk factor is going to be tobacco.
Yeah, and so the red flag with laryngeal cancer is hoarseness that lasts more than 2 weeks. And the most important person that could diagnose this is someone that knows you. So you wouldn't want to go to an urgent care and be like, hey, I'm hoarse, or talking to them because they don't know the normal sound of your voice. So this is where your primary care provider, someone that knows you, would be like, hey, your voice quality sounds different, because oftentimes the people that we live with don't recognize a subtle change. As the tumor grows around our vocal cords, we don't notice that subtle change to the voice quality. So we see that.
So gotcha. So let's do one final rapid review. So if oxygen is low, check device.
Check the flow rate.
Check your patient.
Check the lungs.
If the trachea shifts.
Think tension pneumothorax.
If chest tube bubbles continuously.
Think air leak.
If COPD gets sleepy on high oxygen.
Think CO2 retention.
And so respiratory isn't hard because it's complicated.
It's hard because it's layered.
So air moves,
Oxygen diffuses.
blood perfuses.
Cells use it.
Miss one step, the body spirals.
They're not easy,
They're just hard.
and we can do hard things. Tune in next time for our next episode. Make it a great day.